Good evening. Hello. Yes, actually, the neurosurgeon here acts a bit as a bricklayer in the end of the whole project. You are the big heads, the smart part, but someone has to bring and put all this stuff in the brain. There are actually 5 ways to bring a drug into the brain. One is to inject it intravenously, but of course you need high doses, you risk systemic reactions. We can use 4 ways to bring it directly to the central nervous system. One is the easiest is the intrathecal. You just do a lumbar puncture in the lower part of the spine and inject it and inject the drug. Then is the third, the CM, which is the cisterna magna, is the small, tiny space in the back of the brain. The ICV, which is the intracerebral ventricles, this is the most common. And the intraparenchymal, which is somehow rarely used and requires some different approaches and techniques. These are all procedures that at a certain level, at a certain point are risky. And one should, of course, answer to the question whether is the risk of neurosurgery justified? And the answer, of course, is yes. These are all serious conditions, serious, severely affected kids. And beyond that, we have actually many ways, many methods to decrease the risks. We know that the brain has a a big potential for recovery, much bigger than the spinal cord. If you have a damage to the spinal cord, you will suddenly see it in a person. If you have a limited damage in the frontal part of the brain, you might much reasonably not notice it. Of course, we need to know where the important part of the brain, which are the eloquent parts, to avoid them. And of course, we need to properly use the technological assistance, mainly neuronavigation, stereotaxy, and if the hospital has one, the robot, we do not have it. So these are the 3 approaches that might be used. The intrathecal is the one on the left side. We just inject it in the lower part of the thecal sac. Then in the middle we see the cerebral ventricle approach, which is the most reasonable to be used. And on the right side, the injection in the cisterna magna. There have been a lot of questions and thoughts about this approach also for the Urbagen drug, but this is an old method which has been used in the past. The back of the brain, the junction between the brain and the spinal cord, is extremely dangerous. There are some tiny and very important vessels which actually we prefer not to take the risk to damage them. If we inject a drug into the lower part of the spine of the thecal sac in the lumbar spine, this is quite a complex image, but we see that there will be a higher expression, a higher concentration of the drug in the spinal cord and the low concentration in the brain. If we inject it in the ventricles, this is what this image shows, we will see that the concentration all around the brain will be much higher. So it is again reasonable that the ventricles are the best target. How do we access to the cerebral ventricles? These are quite tiny spaces in the middle of the skull, in the middle of the brain. This is quite an easy procedure in the end, technically. In general practice, neurosurgical practices, it is used quite often. The problem is that we usually do it in enlarged ventricles when people, after adult and kids, when they have a hemorrhage or a tumor, then as a reaction, these ventricles enlarge, and it's quite easy to puncture them. The problem is when the ventricles are narrow, you have actually to hit a target of 2-3 millimeters in the depth. That's why we absolutely need technology, as we will see. Then there is a lot of there are many questions regarding whether we should do it on one side, both sides, whether we should inject it unilaterally or bilaterally. There are quite opposing minds and responses. One way of thinking is that doing it unilaterally brings less risks. Of course, the risk is exactly the half. And this study, quite recently presented, shows that the unilateral should be preferred. The two ventricles are connected in the middle, but and we know that if we inject, for example, fluorescein, which is a colored substance, into one ventricle, it will automatically spread all around. But here we are not talking about fluorescein, but about a transduction of an AAV9, which has a completely different dynamics. So there are several methods of delivery where we have been thinking of doing it bilaterally to have a better concentration and a clearly better and sure concentration, which is supposed to be equal on both sides, on the left and right, while we are actually not sure whether this could be reached by injecting it only on one side. As every surgical procedure, the external ventricular drainage has a risk, which is low. Literature and neurosurgical books state the risk at 5%. This is a paper from my residency years, where we actually had no complication, but this was just on 100 cases, all adults. But yes, we must keep in mind that hemorrhages, bleeding, strokes, infections, seizures are all potential risks, which we cannot really avoid even by using all available technology. There are some catheters which are impregnated with antibiotics, but we are not going to use it for this gene therapy. We will use normal, simple silicone catheters. Of course, then we need to use the neuronavigation, which is a kind of, it's more or less the same as navigating with your car on the street. This camera in the middle actually shows you where exactly the tip of the instrument is, and you can easily follow the location on the screen. In neonates, we can use the ultrasound just by placing the probe on the fontanelle, but these children will all have their fontanelle closed. It is important to have a protocol, to have strict rules and about the pre-operative, the operative, and the post-operative way of doing it. And this is why we are now building, thank you, Spele and Damian, and to all people involved. The protocol is somehow done. We need still to approve it. To conclude, these therapies might really bring a great amelioration to the condition of these children, and all these risks, which we must know are we need to know them, and the risk is absolutely the cost benefit is allows us to do it. So I'm quite excited, as all of you, to start this program in the next, I hope, months, with one of my colleagues, Dr. Benedicic, who will probably assist me into the procedure. Thank you.